अपना फ्लायर ऑन करो ना दीपेन। Yes. Good evening, all. It's a Friday evening. As per our ritual, we are starting Case Me 28, and today is our host is none other than our dynamic president, Dr Manisha katikar madam. Today's topic is neuroanesthesia tips and tricks. Madam is president Maharashtra State Chapter ISA, everybody knows. Also associate editor of IJ, and even national ISA coordinator for clinical and cultural events. Madam is a chief anesthesiologist and intensivist at Balwant Institute of Neurosurgery and Intensive Trauma Care, Solapur. Presented and published many articles, many papers, received but Best Paper Award. Faculty at various national, state, and zonal anesthesia, neuroanesthesia conferences from year 2000. Madam is GC member Maharashtra Chapter ISA between 2008 to 2010. Founder editor of newsletter of Maharashtra State Chapter ISA, NISA News from the year 2008 to 2012. Held various posts of Maharashtra State Chapter ISA as a secretary-elect, secretary, vice president, and president-elect from 2014 to 2021. Received Proficiency Award thrice at ISOCON Kolkata 2017, ISOCON Bangalore 2019, and ISOCON Ahmedabad at 2021. Received COLS Award at ISOCON Ahmedabad 2021. Received Dr. Rukmini Pandit Award at ISOCON Ahmedabad 2021. Prestigious awards and so many lectures given by Madam. And it will be wonderful talk today's also. So please, ma'am, it's your turn. Please share this.
Thank you so much, Dr. Sachin, for such a nice introduction. And definitely it is my pleasure to be with you all today for this presentation, especially the topic which is very close to my heart, which is I'm practicing day in and day out, that is neuroanesthesia tips and tricks. I hope you are all able to see my screen.
Yes, ma'am.
Yes. Thank you so much. Actually, the topic that was been given to me by Dr. Sachin, neuroanesthesia tips and tricks, and that to cover in a lecture of 30 minutes, it's just impossible task. But what I'm going to do is I'm going to give some important points that will help all of us to at least formulate a plan for any case, any neurosurgical case, any intracranial case that will help us for proper anesthesia management and proper emergence. So I begin with my topic. We know that there are advances in neurosurgical interventions, there are advances in neurological monitoring, and of course, there are advances in neuroanesthesia too. So the neuroanesthesia is expanding, developing, and the knowledge and expertise of we, the neuroanesthesiologist, as well as neurointensivist, is definitely influencing the patient outcome. So though there are advances in all the techniques, but the basics of neurophysiology or the neuroanesthesia is still unchanged. We need to provide optimal operative condition, we need to maintain cerebral perfusion pressure, and we need to maintain the cerebral oxygenation. So how? We will see in next few slides. Before going into the depth of tips and tricks that are related to neuroanesthesia practice, we'll just refresh our knowledge of cerebral physiology. You all know that brain constitutes about 2% of total body weight. It gets 15% of cardiac output. There are no stores of glucose, and the global cerebral blood flow is around 50 ml per 100 gram per minute. The cerebral blood flow, if it falls less than 10 to 23 ml per 100 gram per minute, the signs of cerebral ischemia will develop and there may occur a neuronal damage. And if it falls below 8 ml per 100 gram per minute, irreversible neuronal cell death may occur. Cerebral perfusion pressure, I said that we need to maintain the cerebral perfusion pressure. So what is it? It is an effective pressure that drives blood flow to the brain. So it is nothing but then, how it is calculated? It is nothing but then, just give me, I'm just going to move these images to the left of the screen so that I will be able to see my whole screen. Okay, so how it is calculated? It's simple formula, mean arterial pressure and intracranial pressure. So this is the mean arterial pressure, that is the most important criteria for us, the anesthesiologists, which will be monitoring intraoperatively and, or I would say perioperatively, that will help us to achieve or maintain adequate cerebral perfusion pressure. If there is an increase in intracranial pressure, it can definitely compromise cerebral perfusion pressure as well as cerebral blood flow. So as you can see in this chart, this is the intracranial volume pressure relationship. As the volume, intracranial volume, either because of increase in CSF or blood, it goes on increasing, the intracranial pressure also starts increasing. And initially there occurs volume compensation, but a stage is reached when the volume compensation phase is also exhausted, and here the ICP starts rising and there is a risk of herniation. So this is a very crucial stage in the neurosurgical anesthesia or in the neurointensive care, which we need to monitor and manage very efficiently. And next 20-25 minutes, whatever I am speaking is to avoid this crucial state so that we'll have a great, a good neurosurgical anesthesia and a good recovery. You all know the famous Mandro-Kellin doctrine. Brain is a compact structure. It doesn't have a space other than brain, blood or CSF. So any factor that cause rise in either a brain tissue, maybe a tumor or a mass, maybe a hematoma, if it is in a blood, or maybe increase in the CSF either because of hydrocephalus, is going to affect the total intracranial blood volume, and then there is a risk of herniation. So as you can see, if there is increase in the size of the brain, increase in the size of the blood volume, or increase in the size of CSF volume, all can lead to raised ICP, neurological injury, and there is a risk of cerebral ischemia. And this important slide, see, so many things are in our hand. The neuroanesthesiologist, the neurosurgeon, and the neurointensivist are going to manage so many compartments. Basically, the practice of neuroanesthesia is the total perioperative care of a neurosurgical patient. So when there is an increase in the size of brain volume, then neurosurgical intervention will help to control the intracranial compartment. If there is an increase in the fluid level, then diuretics, mostly the osmotic diuretics, or if there is a tumor and then because of that there is a vasogenic edema, then steroids will help. CSF drainage to decrease the ICP, either by anesthesiologists by doing the lumbar puncture or by surgeons, will help in decreasing the edema. And if there is a hematoma, maybe a arterial slide, intracranial hypertensive bleed, or a meniscite, maybe a cerebral venous infarct or hematoma leading to because of cerebral venous infarct. All these factors are well managed by proper anesthesia management as well as proper neurointensive care management, and when required by good neurosurgical intervention. So when we anesthetize this patient, we need to monitor the intracranial volume loop relationship. Avoid any factor that will cause rise in cerebral blood volume, that will increase the ICP. And what are these factors? See, all these are in our domain. Monitoring, giving proper anesthetics, maintaining the mean arterial pressure, maintaining the CO2 levels, maintaining the oxygenation, all these factors are in the domain of the neuroanesthesiologist. So therefore, most of the good intraoperative neurocritical care or neurosurgical care is given by the neurosurgical anesthesiologist. And the main goal in anesthetizing this patient is to maintain the hemodynamic stability. So let us begin from the preoperative neurological evaluation, which is very important in these patients to have the successful outcome of neurosurgical intervention. So whenever we see the patient in the history, we must ask the details of seizure. Whether the patient got convulsions anytime, what kind of convulsions they where they were tonic, clonic, where they were generalized, how frequently the patient got convulsions, when the patient had last convulsion and how they were treated. Did he need hospitalization and injectable anticonvulsant at that time? Did he go to the consulting and got treated in the at the outpatient department only? Was there any change of tablets for tablets of anticonvulsant or the anticonvulsant drugs done at that time? Is there any increase in the dose of anticonvulsants done at that time? So such kind of history will tell us the details about the epilepsy that the patient is suffering from the neurological problem. Are there any signs of increased intracranial pressure, headache, nausea, vomiting, blood vision? Is there any history of decreased level of consciousness, somnolence? Are there any focal neurological signs like hemiparesis, sensory deficits, cranial nerve deficits? The physical examination must assess the mental status. One must know the Glasgow Coma scale. One must find out a Glasgow Coma score for that patient. If there is a papilloedema or not, that can be seen. It indicates raised ICP. If there is a hypertensive bradycardia, it indicates raised ICP as it is a sign of Cushing's response. One must see the pupillary size in speech deficit, gait deficit, Glasgow Coma scale score, and any focal neurological signs. In the drug history, one must ask about the history of steroids, since how long the patient is on steroids. Usually, if it is elective surgery for a brain tumor excision, then the steroids are usually started after hospitalization. And as I said, the detailed anticonvulsant or antiepileptic drug history must be sought, and the patients must receive morning dose of all the antiepileptic drugs on the day of surgery. Most probably, whatever practice I do, I usually give the oral dose only, because intraoperatively you need to give the loading dose again, and the postoperative dose, if the patients are wide awake, are again given orally. The next important investigation as an anesthesiologist while managing these cases, you must know is reading CT scan or MRI. This type of this examination in the preoperative period is very important. Why? It will tell you about the size of the tumor, about the location of the tumor, where the tumor is situated. Is it in the silent area or the most important eloquent areas like Broca's area? Is it near a major vessel? Are there any signs of raised ICP like midline shift, mass effect? What is the size of ventricle? Is it compressed? Is the temporal lobe shows signs of herniation because of increased mass effect? What about the ventricular size? Is there a hydrocephalus? Is there a CSF space around the brainstem? And if it is a redo craniotomy, is there a pneumocephalus or is there a brainstem involvement? And at the same time, you need to discuss the CT scan or MRI with the neurosurgeons as well as radiologist also, which will give you some working diagnosis of that tumor. What is the tissue type of tumor? I am going to tell why I am stressing this point is that because if the tumor is near a very major blood vessel, or if the tumor has engulfed a blood vessel, then there might be a torrential hemorrhage when the surgeon is removing the tumor. So you need to be prepared for that. If the tumor is a CP angle tumor, that then might occur involvement of lower cranial nerves. Patient may have poor cuff reflex at the end of the surgery, and you need to maintain or ventilate the patient in the post-operative period because of lower cranial nerve pulses. So this kind of evaluation is very important, and this must be discussed with the neurosurgeon as well as neuroradiologist. Then the evaluation of hydration status is very important in neurosurgical patient. This is because patient is on various anti-edema measures as well as diuretics. Because of vomiting, the fluid intake is usually less. They have, most of them are drowsy, water intake is less, and hydration status must be evaluated properly in the preoperative period. So all these preoperative assessment and examination will tell you on what side you will put your IV lines. what will be the position of the patient, how you will anesthetize this patient, whether you will use TIVA, or if the IV line is, whether if once you decide about the position, then will the IV line be accessible to you? Will you need any additional venous access intraoperatively, and will it be possible for you to cannulate that extra venous access in the intraoperative period, or you need to cannulate the vein in the perioperative or in the before induction only? So all the discussion of with the surgeon, with the radiologist, assessment of the tumor, on the CT scan and MRI will tell us the most important thing for an anesthesiologist, that is cannulation of an IV line, that is a lifeline for that patient. Again, after assessment of the patient, you will also have to formulate further points regarding the use of various monitors that you are going to do in the intraoperative period. If the position is prone or a park bench position, then will only be the non-invasive blood pressure monitoring will give me accurate reading, or I would like to put an intra-arterial line. If I would like to put an intra-arterial line, at what level I should keep the transducer? Because if the patient is given park bench or a sitting position, the level of transducers might change, and you need to be prepared for it right from the preoperative period. You need to have a peripheral nerve stimulator if you are in doubt. If you are going to use the depth of anesthesia monitor, it may be this entropy, Conox, whatever you are using. Then on this side, you are going to put your the monitors. While positioning, will it be required to disconnect the monitors? Will it be required to disconnect the ventilators while the patient is positioned? And even the same for vascular access. Will you need to disconnect the vascular access during positioning? So your basic preoperative examination should tell you or should give you answer for all these questions, as you need to be prepared for all these answers when you start this case. Predication as such is a controversial subject. The basic principle in neuroanesthesia is not to sedate the patient heavily. You need to individualize the case and give at least anxiolytics depending upon the patient's Glasgow-Coma scale score. Let us see what is the suggested anesthesia induction sequence for intracranial surgery. After adequate anxiolysis in the anesthetic room, give patients adequate fluid, load him with adequate fluid, the isotonic normal saline, put your monitors in place, basic monitors, ECG, NIBP, pulse ox, CTCO2. If you are, you put your big size gel hose, either a 16 gauge or a 18 gauge gel hose. Plan when to put your arterial line, whether you need that arterial line, or are you going to put that arterial line under local anesthesia or after induction. That also you need to decide. The induction will be give fentanyl as a pre-medication. Maybe if fentanyl or remifentanil it is not available with us, pre-oxygenate the patient. Induce the patient with either propofol or thiopental, whatever you are, whatever will be the drug of choice for you. You can intubate the patient with either intermediate or long-acting muscle relaxants, vecuronium, rocuronium, atracurium, cisatracurium, whatever may be your choice of muscle relaxants. You need to maintain the anesthesia with controlled ventilation. Maintain PSO2 at around 35 millimeters of mercury. To give propofol infusion for maintenance, and if required, isoflurane or sevoflurane for maintenance of anesthesia, and propofol fentanyl doses intraoperatively. Of course, you have a choice of further drugs like dexmedetomidine, now easily available during maintenance of anesthesia. Intubate the patient. The skull blocks, they are the most important part of neurosurgical anesthesia management. So give skull blocks, give local anesthesia, give intravenous fentanyl at a time of all pressure responses like skull pin head holder placement, skin incision. Give adequate head up position so that there is no compression of jugular veins. The aim should be a relaxed brain for the neurosurgeon, so he will be very happy with the neuroanesthesia technique. As soon as you induce the patient, you should start mannitol very slowly, and if the surgeon wishes to have a lumbar dent, that can also be inserted. Start mannitol in such a way in the dose of 0.5 to 0.75 gram per kg, so that by the end of the dura opening, the 100 total first dose of mannitol is totally given. Give it very slowly. No need to give it very fast. Maintain normovolemia. Use isotonic saline, and you all know that we need to avoid 5% dextrose, as it increases the free water in the vein and can cause edema. So the monitoring, the basic monitoring, the depth of anesthesia monitors. Post-induction, you may put CVP line depending upon the situation, the precordial Doppler ultrasound probe, or if you have transvisited esophageal echocardiography, that can also be used. Another important monitoring which I would like to stress in a neurosurgical patient is a temperature probe. So every monitor, the basic monitor, has temperature monitoring. So I will always stress that please go ahead with temperature monitoring in all these patients. And if the surgery is delayed for some time, if it is delayed, or if there is exhaustive neurosurgery, if there is extensive neurosurgery, you need to monitor ABG serum electrolytes and blood sugar intraoperative. So why these three things are important or so relevant in anesthesia, in neuroanesthesia especially? The hemodynamics, hypoxia, and airway. Let's see. The airway management in neurosurgery needs expertise. The primary goal during induction should be a smooth transition to anesthesia while maintaining the hemodynamic stability. Why this is so important? This is because even brief periods of hypoxia or hypercapnia can lead to cerebral vasodilation, and they are very dangerous or deleterious in a neurosurgical patient. Whenever there is intracranial hypertension, which may be reflected as increase in heart rate and blood pressure, then there might occur loss of cerebral autoregulation in a patient who has already compromised cerebral hemodynamics, and it is definitely dangerous for that patient because, as I mentioned, there might occur herniation at the time of induction. So you need to be very careful. The next important aspect after induction is positioning of the patient. Both the anesthesiologist and neurosurgeon, they must have the full understanding of the implications and possible hazards of each position so that complications are avoided. The basic aim while positioning is to keep the surgical field uppermost, which will help in venous drainage. It will avoid a full brain and excessive bleeding. So the field should be uppermost, and that should be the aim while giving any position to the neurosurgical intervention. So whenever you position a patient, give gradual and deliberate maneuvers. This will prevent acute cardiovascular changes. If you are going to make the patient sitting, or if you are going to make a patient give a park bench position, you need to give polar crystalloids to the patient, mainly the isotonic crystalloids. Give proper support to the upper chest and pelvis to prevent respiratory compromise. Padding of all vulnerable areas to prevent thermal injuries, pressure necrosis, nerve injuries, and injuries to the eye is very important. Proper positioning of neck should be done to prevent venous obstruction. And as I said, elevate the head and lower ribs that may help to aid in venous drainage. These are the various positions that are usually used in a neurosurgical patient, either a sitting position or a prone position, a 3/4 prone position, or a lateral position, or a park bench or a lounge position. So if you look at the complications, in the sitting positions, the complications of cerebral ischemia are the maximum. The neurological, the cranial nerve, brachial plexus injury, or the neurological injuries are more common with prone position as well as the lateral position. The airway complications like endotracheal tube migration, edema of face, tongue, neck, respiratory obstruction can occur in sitting position as well as in the prone position. Ventilation, pulmonary complications can occur in the in the prone position more commonly. The cardiovascular compromise, the hemodynamic instability can occur in sitting position, but they are seen to be more common in the prone position. And the important complication, that is the venous air embolism, more common in sitting position, but not uncommon in lateral or park bench position, in a prone or park bench position. And one complication that you must not miss is the eye compression causing post-operative visual loss, which is very common in patients who undergo neurosurgical intervention in prone position. It occurs because of central retinal vein occlusion, and in a patient who has a normal vision, this is more common in spine surgeries who undergo neurosurgical intervention, the spinal surgical decompression in prone position, especially when the head is kept on a horseshoe for mainly the cervical decompression. So this you need to take a proper eye care in these patients. There is something called as chemical brain retractor concept. Whereas when the surgeon is removing a tumor or hematoma, you need to help the surgeon to keep the brain relaxed as much as possible. You should allow surgeon not to use the instrumental retractors as far as possible, because what will happen if the surgeon puts the instrumental brain retractors, then that compromises the brain part which is just lying below the retractor, and this can cause cerebral ischemia. So this is the most important concept, the chemical brain retractor concept. How you can maintain that? Maintain mild hyperosmolarity by using isotonic saline, giving mannitol, and giving even hypersatonic saline doses in the dose of 2 to 4 ml per kg for bone flap removal. Continue intravenous anesthetic agents like propofol in the maintenance period. Maintain adequate depth of anesthesia. Normoventilate patient. Mildly hyperoxygenate them. Maintain normotension. Maintain normovolemia. This, along with head-up position, along with maintenance of adequate depth of anesthesia, if required, the CSF drain, either ventricular catheter, external ventricular drain, if the surgeon needs to put them, or you can request the surgeon, if you see the brain tense, you can request the surgeon to drain the basal cisterns, which will definitely help to decrease the ICP. If you have put in lumbar drainage, then draining the the CSF through the lumbar drainage, and as I mentioned earlier, avoidance of any instrumental brain retractor. So all these will give proper relaxed brain to the neurosurgeon, and that will be the total the surgical condition that is offered by the anesthesiologist will be excellent, and the surgeons will be really very happy with whatever anesthesia you are giving. So what are the drugs you are commonly using? Propofol, thiopentone, etomidate. And if you look at the effects of all of them, all three of them, propofol, thiopentone, and etomidate, all of them are helpful in decreasing cerebral blood flow, cerebral metabolic rate, ICP, maintaining auto-regulation, and maintaining response to CO2. What about the inhalational agents? If you look here, the isoflurane and sevoflurane are better. If the order of vasodilatory cerebral vasodilatation is seen, then halothane has the worst cerebral vasodilatation properties, which can increase the ICP, and sevoflurane has the least vasodilatory potency, and therefore it is supposed to be the inhalational agent of choice in neurosurgery. It is also seen as safe in seizure patients who get convulsions, and also it is found to be if the patient gets convulsions, also if you hyperventilate the patient with a MAC less than 1.5, then it is found to be very useful. So I would say amongst the isoflurane, desflurane, or sevoflurane, which are the three inhalational agents which we are using now, the sevoflurane will be the best amongst three of them. Still, in spite of giving the chemical brain retractor concept, in spite of taking all proper care, if still your surgeon is telling you, "Arey, brain बहुत tight है, कुछ भी कर, do something. The brain is very tight. I am not able to go inside. I don't know. The brain is bulging out," and then you need to check everything very properly in a systematic manner. Check at your position of the head, whether a proper head-up position has been given or not. Check if there is a compression of jugular vein. Is there any airway obstruction, bronchospasm? Is the patient adequately relaxed? What is PaCO2 and PaO2? What is the blood pressure? Is there any pain? Is the patient having fever? Is the patient getting convulsions? What are you using? Any cerebral vasodilators? What volatile agents you are using? Are you using nitroprusside or calcium channel blockers which are causing cerebral vasodilatation? Or if there are any unrecognized mass lesions like hematoma on the opposite side where the surgeon is operating, or even use of nitrous oxide that can cause the problem, or if external ventricular drain has been kept by the surgeon, whether it's a clamped, whether that has remained clamped and that has caused brain bulge. So you need to do this checklist when the surgeon tells you that the brain is tight and you need to relax the brain. So when the surgeon grumbles about your tight brain, you need to further reduce the PaCO2. Acute hyperventilation will help at this phase. Do CSF drainage. Request the surgeon to drain the vessel systems. Ask him to put the brain needle in the ventricle. Go ahead with ventriculostomy. Give additional doses of mannitol as well as Lasix if required. Give additional doses of barbiturates and propofol. Decrease the blood pressure. Maintain the depth of anesthesia and request the surgeon to go ahead with surgical intervention, either a removal of bone flap or a lobectomy, which may help decrease the ICP. There are certain conditions in a neurosurgical patients where you do not understand, whether you must find out the cause and treat it accordingly. So let us see what are the conditions that cause hypertension in a neurosurgical patient. All pressure responses, laryngoscopy, intubation, incision, skin fixation. You need to give additional bolus doses of propofol, thiopenton, esmolol, lignocaine. Maintain adequate depth of anesthesia. Scalp blocks, that's the best thing that you can do to give, so that most of the inhalational as well as intravenous anesthetic, the dose requirement will be less. You can give dexmedetomidine at a time of these pressure responses. Maintain adequate depth of anesthesia. All these factors are causing hypertension in your neurosurgical patient. If the patient is undergoing the VP shunt surgery, then when the surgeon is tunneling the skin during the time of shunt insertion, then there may be sudden rise in blood pressure and there will be tachycardia. So depend the plane of anesthesia, any factor that causes raised ICP, any brainstem handling, any coughing on emergence, all these factors you need to take proper care and avoid hypertension in a neurosurgical patient. What are the conditions that cause hypotension in a neurosurgical patient who is anesthetized? There are various multiple systemic reasons like hypovolemia, your drugs which are vasodilators, which are myocardial depressants, they can also cause hypovolemia. There is a condition called as neurogenic stunt myocardia. This is seen in patients who have raised ICP, and you need to control ICP aggressively. During positioning, which is the most common reason for the hypotension, especially the sitting position, you need to preload the patient with crystalloids. Our aim is to maintain normotension, and you need to manage this hypotension very properly when the patient is given any position. If there is a hypotension and if it is not responding to the routine line of treatment, the most dreadful complication of neurosurgical procedure, especially in a patient who undergoes surgery in a sitting position, is massive air embolism. So you need to be prepared for this to treat the massive venous air embolism. This needs symptomatic treatment, volume repletion, and vasopressus. There is something called as trigeminocardiac reflex as well as brainstem handling. They all can cause hypotension. Inform the surgeon immediately, stop the stimulus, and usually this gets corrected once the stimulation is stopped. What are the conditions that cause bradycardia in a neurosurgical patient? It can occur as a part of Cushing's reflex. You need to control the ICP as a part of intracranial hypotension. This is especially important in a patient who undergo a VP shunt surgery for hydrocephalus. Whenever the surgeon puts the ventricular needle in the ventricle, then there is sudden if there is very high pressure inside the ventricles, then as soon as the surgeon puts the ventricular needle, there is sudden decompression of hydrocephalic ventricles. This can cause intracranial hypotension and bradycardia. So you need to be very, very careful when the surgeon puts the needle in the ventricle to drain the CSF while putting a VP shunt. Bradycardia can also occur because of brainstem handling, vagus nerve stimulation during posterior fossa surgery, or as a part of trigeminocardiac reflex. You need to inform the surgeon immediately, and this will help. If the stimulus is stopped, the bradycardia will usually get resolved. And what are the conditions that lead to tachycardia in a neurosurgical patient? Along with common reasons like hypovolemia, sudden blood loss, pain, fever, hypercarbia, light planes of anesthesia, cardiac arrhythmias, various drugs like even the glycopyrrolate. The most important reason I must say is that unexplained tachycardia. If you exclude all these reasons for unexplained, all these reasons, and if you find unexplained tachycardia in a paralyzed patient who is sedated, intubated during surgical intervention, then the patient might be getting seizures intraoperatively. In such kind of patients, you need to give anticonvulsants, the loading dose intraoperatively, so that you should not miss those conversions that occur intraoperatively because of the handling of the brain tissue. So this unexplained tachycardia is a very important term that one must know. And if you are not able to explain the tachycardia for any reason, give top-up doses of anticonvulsants, give midazolam additional doses, which will take care of the conversions if they are occurring. The reversal, it must be a well-planned procedure. This is because you want a fully awake patient. Your surgeon will be very happy if you give him an awake patient who is obeying verbal commands, and the surgeons are able to do the neurological examination at the end of the surgery. And as I said, the planning of this should start from the preoperative visit. You need to have homeostasis on various fronts, the systemic, the brain, as well as the intraoperative conditions. You should maintain systemic homeostasis intraoperatively. You should maintain the brain homeostasis intraoperatively, and avoid coughing, tracheal suctioning, dyssynchrony between the patient and ventilator at the time of neurosurgical awakening. So, whenever you are reversing the patient, which patients you should reverse and which patient you should electively ventilate. There are certain guidelines. A patient who has adequate preoperative state of consciousness, a patient who undergoes limited brain surgery, in a patient who has not undergone any major brain laceration or extensive posterior fossa surgery, which involves a lower cranial nerves, in a patient who has not undergone any major AV malformation resection, or a patient who maintains hemodynamic stability intraoperatively, maintains adequate oxygenation, and patient who is not hypothermic. All these patients can undergo awakening or emergence from the neurosurgical procedure. So how to go about it? If you are using fentanyl infusion intraoperatively, please stop it 60 minutes before the planned emergence. Allow progressive rise of PaCO2 to normoventilate, because many a times you need to use PaCO2 at a lower level for providing adequate brain relaxation. Let the neuromuscular block, if you are using peripheral nerve stimulator, to decrease it to 2 THs if mild relaxation is used. Maintain normotension. Treat blood pressure burst resulting from nociception. Continue anesthetic administration till skill closure. Rather, I would say here, you should have a loaded syringe of propofol in your hand, and one hand should be on the vaporizer, dial flow of the vaporizer, the sevoflurane. This is because you do not want any rise in blood pressure when the surgeon is changing the neck position, making the patient, changing the position of the patient, making the patient supine from either a prone position or a park bench position. Continue your anesthetic drugs till the patient is made supine, till the dressings are there. Continue sevoflurane, continue propofol. You might have a syringe of propofol loaded in your hand, ready to give it immediately if there is a sudden rise in pulse. You need to avoid that. And why you need to avoid that? This is because if there is a hemodynamic instability, if there is a rise in blood pressure at this stage, then whatever debulking that surgeon has done, whatever the space that has been created by the neurosurgeon in decompressing, the same space will get filled with the hematoma, and whatever was achieved before the surgery. As I said, the Mandrokelian hypothesis says that, doctrine says that it is a fixed rigid structure. So whatever the space that has been removed, whatever the brain relaxation that has been removed, that has been achieved by removal of the tumor, that space will get filled by the hematoma, and surgical intervention may not be successful. Remove the headpins as early as possible. Give additional doses of esmolol or lignocaine if required. Stop nitrous oxide. Remove oral packing if used. Perform adequate suctioning before reversal, before stopping the inhalational agents. Keep blood pressure in the preoperative range by quickly treating the arterial hypertension. Extubate the patient. Perform brief targeted neurological status examination post extubation, and this is the most important step. transfer the patient to the post-intensive care unit. You need to go along with the patient, transfer the patient yourself to the neurosurgical intensive care unit, and reassess the patient again when you shift the patient after shifting the patient to. So you need, why you should have a good recovery? This is because you will get time to assess the patient. The post-operative neurological assessment, this is very important. You will be able to assess the neurological status immediately after surgery. You will continue further evaluation in the post-operative period in the neurosurgical intensive care unit. And if there is any complication, if the patient becomes drowsy post-operatively, then there will be diagnosis of complication by the neurological team without any delay. And if required, immediate CT scanning or surgery, whatever is needed, can be done immediately. But for that, your patient has to be wide awake on table before you shift the patient to the intensive care. So the take-home message: the main objective of anesthesia for any neurosurgical intervention is you need to control the ICP aggressively, avoid brain swelling, maintain adequate blood pressure to maintain cerebral perfusion pressure. It is very important because the whatever action we do is very important, that will avoid the worst complication, that is brain herniation. And for that, you need to have good understanding of interrelationship of neurophysiology, pathology, and neuropharmacology. Thank you very much for patient hearing, and I hope I am able to. I will be more happy to take more questions and answer questions on this topic, as this is a very important topic which we are discussing today: the practical neuroanesthesia management in a patient. I think I'll stop sharing.
Yes, ma'am. You can. Actually, it's a very hectic schedule for you also. You did a lot of jumbling because of your disconnection of Wi-Fi, and still you did this meeting.
I was lucky that I could join on the computer today. Otherwise, I would have to join through mobile. Then I would not have been able to explain everything so comfortably.
You're so busy as a president, madam. How can you manage these things, like joining every meet and with every conferences and doing your private practice also?
Once I discussed this in Solapur. See, everybody has some passion. You know, Dr. Maya Balorov, she's fond of painting.
Yes,
she finds time for it. Every day almost you can see there is a new painting. She finds time for that. She gets up early at around 5:30 when we are all are fast asleep. That time she finds time for herself and she draws the painting. The same thing is with me. I think I have a passion to do this work, which I'm doing for last almost 18 years in Maharashtra. So I think I have a passion for this work, and whatever extra time I get, rather than watching for a movie, of course, my two commitments are there: my work, my practice, as well as my family. But after that, whatever time, whatever time is there for me, maybe it is, even if it is a late evening, you can see my messages even at around 1 o'clock on the WhatsApp also, if they are important. So whatever extra time I get after that, I think I devote this for my passion. So I must say that this is my passion.
I'm really proud of you, ma'am, because you are so much industrious, because you do new ideas I never seen in our ISA chapter of Maharashtra, and I see other chapters also, but activities are more on our platform. Second thing, I want to know that what hobbies you like to continue, or you're keeping that hobbies going?
Yeah, see, basically, I like to read a lot that is related to mainly anesthesia. So as I'm reviewing many of the IJ journals, I'm reviewing two journals.
Yes.
I'm doing reviewer as well as editors. I'm reviewing the articles for Indian Journal of Neuroanesthesia and Critical Care, and I'm editing the articles for Indian Journal of Anesthesia. So they keep me busy many of the times. I enjoy doing that because I know, because I tell you that that is the only chance when I get to read the books, or when I get the time to read the references. And I think I must say that because that keeps me updated. And that is why I think this is my hobby. I do not get any extra time other than this to do any other things. Yes, definitely I don't like to watch a movie or watch a TV serial. That is not my
Cup of tea.
yeah, it is not my cup of tea. I never enjoyed that. I
Yes, yes.
enjoy doing the ICU work. My work, I manage the ICU also in my hospital. It's a 15-bedded neurocritical care and 4-bedded high dependency unit. So all the ICU intensive care unit is managed by me only. And I always feel that in a neurosurgical team, especially if the anesthesiologist who has given anesthesia for that case, if that particular person manages the intensive care, definitely the patient has a good recovery or a good outcome. So I manage the
Yes.
neurointensive care. I do all the procedures in the neurointensive care, and I must say my surgeon is very fast. So we do three or four cases in a day. I'm not tired at around 6 o'clock because usually my OT starts at around 9:30, 10. It goes on till 3 or 4 o'clock average time. And then I have ICU rounds. Our the private neurosurgical unit. I need to talk to the patients. I need to counsel the patients' relatives. I need to see the preoperative patients, which will be posted tomorrow morning. So I do that. And by around 7:30, 8 o'clock, I'm free. Again, I go for evening rounds in the evening in the neurocritical care. And then whatever time I get in between in the OT also, I utilize for my passion.
Ma'am, first question from anonymous attendee. Ma'am, do you use RL for IV fluid management?
Yes, I use. In fact, if you see the references, they have recommended to use normal saline as well as ringer lactate alternatively. Ringer
Yes.
lactate is almost near to the our whatever our plasma. I must say that plasma
Osmolarity.
concentration or plasma osmolarity is there. So I
Yes.
do use. I in fact use. In fact, Miller has given this. I would tell you the reference also. Miller has given this that you use alternate IV pints of ringer lactate as well as normal saline, isotonic normal saline, and I do use that. I do use that. I practice using alternate pints of normal saline as well as ringer lactate.
Second question from Jayshree, ma'am. How you face venous air embolism and how you manage it successfully?
Jayashree madam, I'm very lucky anesthesiologist that I have never faced venous air embolism. The most common reason might be my surgeon is hardly operating in sitting position. So, but we do frequently operate in prone position. So I have never faced this complication, but definitely when I was a PG student in JJ Hospital, when the many of the tumor posterior fossa surgeries were done in in sitting position, that time I had encountered such complications. For such, you have to be very swift. First thing is you need to identify that it is a venous air embolism. If there is a sudden fall in intended CO2 or in the which you are monitoring, then the first thing that should come in your mind that it is an air embolism. Along with that, if there is a hemodynamic, you get very less time if there is a significant air embolism. If there is a hemodynamic instability, you need to treat it aggressively with inotropes as well as IV fluids. You need to gradually decrease the head-eye position, discussing with the surgeon. You need to put an IV line, the central line, if it is there, you need to aspirate the central line and you need to aspirate the air, whatever has entered the right atria. So all these things have to be done simultaneously. You need to have the full assistance from your anesthesia as well as the neurosurgical team to save the patient. It's a dire emergency. You need to act very fast. First thing is you need to identify it as early as possible and you need to act very fast.
So, prior to in my 2008, I started my practice in Nanded. That time I used to do neurosurgery cases regularly. Really, that time even CO was not there in the neurosurgery. They said to me that ISO is best. So I used that time ISO, but now I'm not doing neuro practice presently, but really happy that CO is best choice as you mentioned in this. Uh, Previously, we use as ISO in neuro practice now, but
Yeah, even I used to use when sevoflurane was not available. I used to use isoflurane only. Never used halothane because I think halothane in the initial phases of practice, but then once isoflurane was available, I never used halothane for a neurosurgical intervention.
in your practice, ma'am, how you its feeling of using ISO and CO. What difference can you share with us?
Yeah, what I feel is that the recovery profile, of course, with sevoflurane is much better as compared to that of isoflurane. And second thing, what I have observed in my clinical and day-to-day anesthesia practice is that the rise in blood pressure or the hemodynamic responses are better controlled with sevoflurane as compared to that of isoflurane. And I'm using depth of anesthesia monitor. Even the depth of anesthesia monitor, the depth of anesthesia is adequately achieved in a short time with sevoflurane as compared to that of isoflurane. But the most important, I feel, for a neurosurgical patient is rapid recovery, awakening on the table, and that should be the aim. You should not allow the patient to cough at the end of surgery. This is because even a single bout of cough can cause rise in blood pressure, and that can cause the surgeon has just recently achieved the hemostasis, and that single bout of cough can cause rise in blood pressure. The whole space that in the side that the tumor has been excised, that whole space is filled with fresh blood. There will be hematoma, and you need to take that patient again in the OT. So the aim should be no cuffing, no straining, and that is why you need a patient awake. You need not, you do not want patient in the deeper planes of anesthesia, and that is why you should continue using sevoflurane at least 0.2 dial flow at the end till the surgical dressing is done. In fact, I do even suctioning also with the sevoflurane. I give adequate time for reversal. I am not at all in a hurry to reverse a neurosurgical patient and go fast for another case or induce another case. This is because we need to respect that it is a brain tumor, and we need to respect that the patient must have a good adequate recovery. Because if that patient gets adequate good recovery, you can have a peace at neither परत पेशंटला आयसीयू शिफ्ट केला, ड्राउझी झाला, स्कॅन केला, हेमॅटोमा झाला, सर्जन म्हणणार चला एक्सप्लोर करायचं. You need do not want that. And everything then complicates, the morbidity increases, and even the recovery also creates problem. So for neurosurgical intervention, I must say that sevoflurane, if available, should be used.
I want to know what monitors you have related to depth of anesthesia.
I'm using Connox monitor.
Okay.
I have Connox monitor. I'm using Connox monitor. It shows QCon and QNOX, and I'm very happy with that. In fact, I had presented many lectures in our state conferences also, and even in the neuroanesthesia conference, the National Neuroanesthesia Conference in Mumbai also, regarding QCon and QNOX. I think the Connox monitors, they were made available by the company very easily to many of the neurosurgical setups that time. I must confess that I got it at free, but the cost of that strips is very high, around 2,000 to 2,500 you need to spend for per patient. So, but then it gives you so much additional information that you need to use them, use depth of anesthesia monitor for neurosurgical intervention. Here I would like to stress even the importance of skull blocks. I started giving skull blocks a little late in my anesthesia practice. Little late means once the propofol and fentanyl was easily available.
Yes.
But then,
this question is asked by Poonam. Ma'am, how frequently you use skull blocks?
I use it every patient, every neurosurgical intervention I use, whether it's a trauma, whether it's elective, I use it. And I'm in fact making a prospective study on this, because I've seen in the references that there are many less reports of giving skull blocks in the neurosurgical traumatic neurosurgical intervention. So I'm doing a prospective study also for this, and I feel that the requirement for the anesthesia, or to maintain the depth of anesthesia, you need to have less anesthetic doses. Once the dura is open, everything is insensitive. So what anesthesia you need to give is to maintain the patient should be adequately under anesthesia to tolerate the endotracheal tube. That should be the aim of our anesthesia. So, and then the most painful responses are what? At a time of skin incision, at a time of when the surgeon is putting the headpin, or at a time of skin incision. So if they have been taken care by a good skull block, then definitely it will help you to have good control on your use of intravenous as well as inhalational anesthetic drugs, which will again help you in rapid awakening of the patient. So I give skull blocks recently, not even this, in fact recently I have started giving skull blocks even for trauma patients for last 2-3 years. Even I give for unilateral also, unilateral skull blocks also I give. If the patient is for only for bones, only for posterior fossa decompression, I just block the posterior nerves, greater and lesser occipital nerves. So bilaterally. So even that I practice.
Which drug you preferably?
I am using bupivacaine. I have used ropivacaine. I'm using bupivacaine in a dose of 0.25%. I have tried using ropivacaine, but I feel I'm very happy with bupivacaine. I don't know. I am using even ropivacaine in few cases, but my personal experience with bupivacaine is too good. So I'm still continuing bupivacaine, mainly, mostly in most of the patients. But sometimes if I feel like I use ropivacaine also.
You have any last after giving the local blocks related to skull blocks?
That I have to be very, very particular. You need to calculate the dose properly. And if the dose requirement is coming around 40 ml, give 30 ml. If by weight, if the dose requirement for 0.25% bupivacaine is coming 40 ml, give 30 ml. Give properly, block the nerves properly, and the main aim is to have adequate analgesia of the skull. That helps in the post-operative period also. I had recently read the various papers, in fact, adding dexamethasone to this bupivacaine for prolonging the effects of block. Clinically, unfortunately, I have used it in few cases, but I did not get that response. So now I have again started using plain bupivacaine.
Next question is, how do you treat hypoglycemia in neuro patients?
Avoid hypoglycemia. I do not want my patient to be hypoglycemic. Let them be on little bit hyperglycemic side, but no hypoglycemia, not allowed in neurosurgical practice. You have to have rigid control of blood sugar intraoperatively. Maintain your blood sugar between 120 to 180. If there is a hypoglycemia, you need to give some dextrose because if the patient is anesthetized, but the basic aim is avoid hypoglycemia. Keep the blood sugar side around 150 to 180. Do blood sugars every 1 hour. I have mentioned in the laboratory investigations, intraoperatively, you need to monitor the blood pressure, blood sugar. So avoid hypoglycemia is your aim, avoid, and that is the most important thing. And if they occur, of course, you need to give, I prefer giving 50 ml or 100 ml of DNS rather than giving 25% dextrose, which will add more free water to the brain.
Related to some awake craniotomy, any experience related to it?
Yeah, see, the awake craniotomy is a totally different experience, I must say. It is a totally different experience than what you are doing the neurosurgical case. You need to have neurological monitoring intraoperatively. Unfortunately, we get the team and you need to have a neurophysiologist also. Unfortunately, in Solapur, we lack that facility. Even in my setup, there is no monitoring, neurological monitoring done. Monitoring was done a few years back. But now we get a team from Pune. We hire a team from Pune, which comes with the neurophysiologist. And we have started doing good amount of awake craniotomies also. People are happy using dexmedetomidine. My personal experience of using dexmedetomidine for neurosurgical anesthesia for awake craniotomies is little less. Maybe I'm more in favor of always fentanyl given in titrated doses and propofol, and that is why I go on giving fentanyl top-up doses, assessing the patient's neurological status, avoiding respiratory depression. Yeah, and you need to, the most important thing is for awake craniotomy is that in the pre-operative period, you need to sit with the patient for almost an hour. You need to explain the patient the procedure, what exactly is done in the OT. That is very important. The counseling part of awake craniotomy is very important. You need to explain the patient that you will be there in the OT to take care of that patient. You may be able to hear the voices of drill, drain, suction. You may be able to hear the conversation also, but don't get scared because I am there to take care of you. Even if you feel any problem intraoperative, you can tell me that. That counseling is the most important part of awake craniotomy. And the second most important point is that your OT needs to be prepared. Your OT staff needs to be prepared for awake craniotomy. There should be no extra discussion. There should be no music going on. The mobile should not ring. The mobile of all the OT staff should be on silent mode, not even vibrator mode. In fact, they should be out of the OT. This is because whatever, if there is a phone call, and if you listen to that phone call also, that might disturb the patient. So the OT environment in the OT, the pre-counseling, and the even the AC temperature, even I can say, because that hypothermia may affect the patients. Already the patient is anxious and scared, so that hypothermia also can affect the patient's general condition or the psychology to face the surgical intervention. So this basic preparation of the patient for awake craniotomy is more important. And I go ahead with propofol and fentanyl, titrating the doses. There are complications like convergence intraoperatively. Luckily, I have not faced such complications, but you need to be prepared for that. Laryngeal mask airways and rescue for airway management in such cases if there occurs respiratory compromise. So that should be handy in your with you. And everything that can be done to assess the airway, to access the airway, should be done right from the beginning after discussion with the surgeon. So that is also needed. You need to talk for any neurosurgical intervention. You need to talk with the neurosurgeon in depth regarding everything what he's going to do.
Again, question from Jayshree Madam. Do we have some challenges in using mannitol intraoperatively?
Challenges I did not get, because that is a drug you need to give to decrease the brain edema. I did not get the question properly.
Do you have some challenges in using mannitol intraoperatively?
Challenges.
Yes, ma'am.
See, if you give the mannitol very fast, that is harmful. You need to give mannitol in a proper dose, in a proper way. I told you in my lecture also that you start the mannitol once everything is stabilized, once before, after the positioning the patient. Start even if that 100 ml mannitol is started, give it very slowly till the time the dura is open. This is because you can see rebound rise in ICP if you give mannitol very fast. So that is why mannitol has to be given very slowly, and I think if you give it, and I must say that this the proper method of giving mannitol was taught to us by Dr. Kondvilkar madam in the JJ OT, and I have not forgotten that till then. And the way she used to teach us how to give mannitol, and I think I have never seen any complication with the use of mannitol. I'm not getting the question what other complications are expected.
Yes, I'm also.
Rebound rise in ICP is known with mannitol if it is given fast.
In Nanded, when I was using mannitol, my surgeon told me use Lasix also with that.
Yes.
So
yeah,
see, doubly.
When the surgeon tells you that the brain is very tense, already you have given mannitol, already you have given steroids for vasogenic control of vasogenic edema. You have stopped your inhalational agents. Your patient is on total intravenous. You have given bolus doses of propofol. You have stopped nitrosis. And at that time, the thing is left in your hand than to give a diuretic, especially a loop diuretic like Fusimax. So I also give Lasix whenever there is a stressful situations for a neurosurgeon with a tense brain. In fact, to manage a tense brain also is a very important task that a neuroanesthesiologist has to perform intraoperatively. The neuroanesthesiologist has to be very vigilant, very. I must say that you need to develop your the ears, the voice of the tick of that ECG or the pulse ox. That has to be, because you cannot see at the monitor all the time. So your ears need to get trained. Your eyes, your ears are your useful weapons in the OT, which will help you to detect any problem intraoperatively. And I think, again, salute my JJ teachers who have taught me these basic things in neuroanesthesia, not in neuroanesthesia, in fact in anesthesia. So you need to have your ears trained to listen to the voice of that beep. Many times I see anesthesiologists not making that beep on. In my OT, that beep is always there on. It should not disturb the surgeon also. And if you are sitting quietly on a chair in the OT, the surgeons are very happy. They want to sit like that throughout the surgery, because they know if you are sitting like this comfortably, then the patient is absolutely safe. If you're moving, you're getting out of your chair, moving around here and there, asking for someone to come, then they know that there is something going on, something, the patient is unsettled, they will immediately ask you. So that kind of atmosphere. You try to maintain your routine. Sit, relax, because neurosurgical cases will take definitely some time. So relax, sit in the OT quietly. All your senses, eyes, ear, be vigilant, and they should hear that beep. They should, your eye should watch everything, the monitor, your anesthesia machines, as well as the surgical intervention that's going on.
So in my that line, I'll really appreciate that. When I'm new to the practice, that some surgeon, when I went to that hospital, and I was really embarrassed. Or sometimes like anxiety is there in my attitude. So I don't sit in my chair. I always standing beside patient's bed. So surgeon told me, "अरे आप बैठ जाइए ना, क्यों खड़े हो? Any problem?" I said, "No, sir, nothing." But still, then I become slowly, like to sit in my chair now.
Yeah, yeah.
But in the junior days,
yeah,
it's
I'm
very
telling
difficult.
you that I'm telling you my day-to-day practice in this now. But in the initial period, of course, when we were juniors, of course, we were most successful. But for now, with the experience of doing many cases, maybe the situation has changed.
Yes. It's a really wonderful talk, ma'am, this evening. I'm really grateful to you that you came on our platform, and we are conducting as we thought. This is our Platinum Jubilee celebration year and our City Branch Silver Jubilee year. So we are conducting this, and we will do henceforth also. And
yeah, I think this was the 28th meet, no? This
yes,
was the 28th meet.
Yes, ma'am. And next is Dr. Khade, sir, beyond CTR.
Yeah. I will join that. Because it is definitely, I would love to listen to Dr. Sujit Khade and his opinion
this
about.
This is a running car CTR. Then Vibhavari Naik, ma'am, is there on cleft palate and surgeries. And then after that, Umesh sir is coming on our platform for it's a multi-centric trial about related to ISA guidelines related to perioperative investigations to be done on newer guidelines that developed by Bala sir and
Yes.
That will be taken by Umesh sir. After that, Divan sir's topic is there. And in this era of ultrasound is really needed ENS. That was also one topic. Many more are coming stalwarts in coming future.
I wish you all the best, because to conduct this kind of activities every week is definitely a difficult task, because you need to keep yourself fit, and it's definitely a Herculean task. You are managing your private practice and as well as arranging these kinds of webinars every weekend. Salute to you, ISA Nanded and Dr. Sachin. It's definitely a tough task.
Yeah. In your near future, ma'am, with the other societies of Nanded, I'm trying to giving MMC points for this case meets.
Yeah.
With collaborating with one case meet with other faculties and our faculty, so we can get 1 point at least, so members can earn that also continue medical education.
Yeah. Wish you all the best.
Thank you. So I'm concluding this session. Thanks a lot to all viewers. We will meet next Friday on Beyond CTR. It's a running car CTR on a friend by a friend, Dr. Sujit Khade. So please join. Thank you, ma'am.
Thank you so much. Thank you so much for inviting.